novel oral anticoagulants, and it's now upon us to implement them. Therefore, I would welcome any questions to Jörg Beer, and maybe I start with the second topic you touched upon, and that is the patients who are actually on the vitamin K antagonists. Now, you convincingly showed the variability of many patients who take vitamin K antagonists, and if there is one consistent benefit with the novel oral anticoagulants, it is the decreased risk of intracranial hemorrhage. So my question is there any patient who is on a vitamin K antagonist whom you should not consider to switch actively to a novel oral anticoagulant?
Yes, thank you. I would switch it around because there are so many patients who should be anticoagulated and are not. And these are very good candidates for the new ones. So the rule of thumb is then about 50% that should be anticoagulated are not. And about the other 50% that do not have a great TTR. So I think it's a minority who has a great TTR, and these are not the ones to attack in priority. But I would, in practical issue, I would sit down with my patient, give them the opportunity of both issues, both possibilities, and usually they have a very clear-cut idea which way to go.
So you make an individual assessment. Let me ask you in terms of compliance and follow-up. Obviously, with the vitamin K antagonists, it was the routine to ask them to come regularly for a checkup and to test their INR. How does this advent of novel oral anticoagulants change the way we should follow patients? Is it no longer necessary, or do you address different things when patients come to your office?
Compliance is the first issue. We know from other studies, like antihypertensives, that after 1 year, 50% are off the drug. So compliance checks is a big issue with the new anticoagulants. And poor TTR due to poor anticoagulants will not be a lot better with the new anticoagulants. So not measuring anymore, not looking makes not things better. So we at least have some issue. But in the beginning, it's certainly good to have them back, to consult them, to check their renal function, to check their interfering medications, to consult them on antiarrhythmics, on antiplatelets, and pain medications. So there are a lot of possibilities to have them in your office. And one rule of thumb would be at least 1 month later, and then tapering down at least three times a year the renal function.
Please.
Dr. Vollat.
When we are at medical meetings, the question of costs doesn't seem to exist. When we are outside in real life, the cost is an important issue. Now, if we would switch 80% of the patients to these new anticoagulants, what would you guess the costs would be for Switzerland?
This is an important issue, has been studied for most of the new anticoagulants. Shaw, in circulation like 2 or 3 years ago, showed that it's strongly combined or correlated with the outcome. If you reduce only a few strokes that cost between 50 or 100,000 and you include these costs, then you're with the new anticoagulants reach cost effectiveness. If you assume that the quality life here is about 50 to 75,000, that is accepted with the renal with the dialysis patient that costs about as much per year, then these data that do not only include the cost of the medication, but the cost of the visit, the cost of the INR testing, and particularly, and this is the most important one, the cost of the bleeding, the IC bleeds, and the strokes. Then according to our calculation, it's cost effective. But you're right, you're saving money in different health professions. So the practitioner will probably gain a little less, and other society and insurances will gain more.
But one has to acknowledge it's one of the few therapies which is not just more effective, but also seems to be cost effective.
Exactly.
Maybe another practical question relates to the utilization of different doses as it relates at least to the agent dabigatran. In the United States, there's FDA approval only for the higher dose. We have approval of both doses. How do you choose in practical terms one dose versus the other?
It's a question of values. So the patient at bleeding risk, the elderly patient with other risk factor, the co-medication patient, you're glad to have probably the lower dose. The FDA and the Americans were likely afraid that everybody would be using the lower dose who had no additional benefit, but had in terms of stroke, but had the benefit of the bleeding. So in Hamilton, the Canadian group there, together with Connolly, proposed a scheme to look at the HAS-BLED and the CHA2DS2-VASc score, and then to decide the rather bleeding elderly patient with the lower dose and the high risk of stroke with the higher dose.
If there are no other questions, thank you very much again, Jörg, and we would continue with the next